Hello, my name's Sophie Wilson. Good morning. I'm an employee of International Medical Press. These are my disclosures. International Medical Press is a provider of IME, CME in Europe, and we do receive funding from the pharmaceutical industry, but in the form of educational grants. IMP is also a member of the Good CME Practice group, and what I'm going to talk about today is some of the standards of CME education that we talk about when we meet. So following this presentation, I hope that you will have a better understanding of how the environment for education for CME is changing in Europe. I hope that you'll be able to describe some of the key principles of quality and effective CME, and make a link between the effectiveness of education, appropriate education, transparency and balance, and how these can help you have high standards of education. So my title said this is a changing world. Yes, it is a changing world. There's increasing mobility of patients, of healthcare professionals across Europe. That may even change more as Brexit approaches. As a result, there's a wide variation in medical training, in competencies, in skills. There's an increasing need for accountability and transparency. Our patients are having access to the internet, to each other through social media. They're becoming more and more informed, and as a result, more and more demanding. And so it's really important that the medical profession is able to safeguard patients and ensure the highest standards of care. There's also increasing needs and diversity of practice. Rheumatologists are no longer working in splendid isolation. They need to work with the cardiologist to think about the systemic impact of the disease. They need to work with the gynecologist, because these young ladies will want to have children. So multidisciplinary, interdisciplinary practice is becoming more and more important as well. And then there's technology. So there's this nice slide by Paul Saunier about digital healthcare practice. We used to just have the phone. Now we have social media, wireless sensors, devices, connectivity. You're able to 24/7 monitor your patient. They're able to monitor themselves using wearable devices. Everything's changing, and are the players changing? So here I've identified just very quickly, before we talk about medical education and standards, is a definition of medical education, and it's continuously changing. If I say medical education, continuing medical education in lowercase, you've got industry-controlled product education, you've got industry-initiated education, you've got collaborative partnerships, and then you've got what I call CME, which is accredited or accreditable independent medical education. And I think the independent is really important there. But I think it's important that everybody's aware that the definition of continuing medical education varies, and people use it in very different ways. So it's really important that you look at that. So I'm today going to just talk about IME accreditable CME. And what's important here is that it's consistent. And the problem is that we're faced as providers, we're faced every day with conflicting requirements. The accreditors want independence. The accreditors want us to talk to the faculty. The accreditors want us to contract with the faculty. Yet the supporter, the pharmaceutical industry, for example, their compliance team, they don't want to influence the content, but they want to contract with the speaker, for example. And so there's a lot of conflicting requirements. So who are the providers? The HCPS in the US talk about medical schools, medical societies, insurance companies, accredited providers. Other systems talk about, say that a provider must be aligned with a speciality or must be a physician organisation. Now, as education companies, we're not physician organisations. We're not necessarily aligned with a speciality. So what is our role? And I think there's a lot of talk out there. In Europe, as long as you have a medic who is going to take responsibility for the programme, it seems that by and large anybody can do education. I would question that. And then there's new stakeholders. You only have to look. Next week there is the Digital Health Conference in London. And here you have people like Google, like Siemens, like Arm, who are all beginning to, they're all keynote speakers at this conference. What's their role? Are they providing education? Are they just providing the technology? You know, so it's really important to understand the role of the provider and how, with all these this explosion of stakeholders, how do we maintain standards? And that's really what I want to focus on today, is how we maintain those standards. And so in the Good CME Practice group, we talk a lot about what makes good CME. Is it adhering to the rules of the accreditors? Is it adhering to the rules of the compliance teams amongst the funders? Or is it something else? Well, I think we've identified as a group of education suppliers, providers in Europe, we've identified 4 elements that we believe if you can adhere to these, then you will achieve high quality education. And they are appropriate education, effective education, balanced and transparent education. So I'm going to talk about these 4 principles in a little bit more detail. So, appropriate education. What is appropriate education? Is it education that you just, you happen to be a cardiologist, so you will do education on cardiology? No. It's education that addresses a gap in clinical knowledge or competence or performance. So, gap analysis and needs assessments are really important. Also, for whom is the programme being developed? You really need to know your target audience before you develop the programme, because as we've seen, physicians come from all parts of Europe, there's a lot more mobility, they will have different needs and different skills. What should they learn? So really it's about identifying the gaps and then defining the learning objectives. And then it's how is the subject, the content, the skill best learned. And here I've highlighted educational strategy because in all the definitions from EACME, from HCPS about who a provider should be, nobody's talked about teachers, about educational principles. And this is really where the role of the provider comes in, because not all doctors, not all medics are good teachers. And more at IMP, when we talk about to our speakers and to our faculty, we talk about educators rather than presenters and speakers, because we think it's really important that the people involved, the team involved in our programs, are aware that they're teaching. They're not just lecturing, because people don't take things in if it's a didactic lecture. So I think that's really, really important. That your education is appropriate and the right teaching style. And then it's, okay, so you've developed a programme, but have you actually taught anything? Is it good education? So evaluation and outcomes measures are really important so that you can measure the impact of your education. And it's continuous lifelong learning, isn't it? Doctors need lifelong learning, but so do we. We need that feedback so that we can improve our programmes and make sure we target our audience appropriately. Here, effective education. Now this is hopefully you all know about the Moore pyramid. It nicely illustrates how CME is changing. In the past, CME used to be participation at a symposium, satisfaction, a little bit of learning, but now more and more the focus is on competence, on performance. Because if doctors can't take the learning back with them and implement it in their hospitals, their competence and certainly their performance is not going to improve. So these are really important things that you need to bear in mind when you're designing the education. And that then lets you move up this pyramid to improving patient outcomes and the ultimate goal, community health. But really I think 3 to 5 is where we as traditional CME providers fit in best. Transparent education. This is about doing the right thing and showing you're doing the right thing. Documenting the independence of your planning. Disclosing who is supporting it, who is funding it. Disclosing relevant relationships, potential conflicts of interest, and mitigating them. And I think the mitigation, I should possibly have put that in bold, because there's no point in just collecting conflict of interest forms. You need to read them and you need to react to them and show that you've done that and disclose it to your learners. Also, it's all about trust and accountability here, really. Then there's balanced education. If it's balanced, the content will be reviewed, it will be directed by an appropriate faculty, not just the doctors you happen to know. It's really important that your faculty are selected, your educators are selected according to their knowledge and their skills, so that your education can be balanced as well as appropriate. The content has to be evidence-based, reflect standard care. Not, and this is probably the most important bullet point, it can't be influenced by the supporter, because it's all about perception. The supporter can't be involved. However unbiased they want to be, the simple fact that they are funding your activity means that there's at least a perception that it can be influenced and not independent. Potential conflicts of interest by faculty individuals involved in the content must be identified and documented and disclosed to your learners, so that the learner knows exactly what the faculty's interests are. And they must be communicated. So, sort of take home is, for me, is that if you want to develop good CME, if you go with these 4 principles of appropriateness, effectiveness, balance and transparency, then it doesn't matter who is accrediting it, in which country it is. If you do those things properly, you should have a chance of reaching high standards. Thank you very much.